Hi, I'm Dr. Bill Gradishar, Professor of Medicine, and the Betsy Bramson Professor of Breast Oncology, Chief of Medical Oncology and Hematology at Northwestern University in Chicago. So sequencing of HER2 positive breast cancer patients with respect to therapy is something that's become more challenging. And it's really only a function of the success of new therapies that have come online and available to clinicians. And by that, I mean we now have many more choices than we had in the past. The historical algorithm until very recently was that you use a Cleopatra-like regimen as the first treatment, which implies that you're giving a taxane with pertuzumab and trastuzumab, thereafter TDM1, and from that point beyond the second line therapy, there were a variety of choices that usually included switching out the chemo with trastuzumab, or even things like lapatinib or neratinib could be considered. So what's new, of course, is that we've gotten the Destiny 3 trial data back, and that was preceded by Destiny 1 that looked very encouraging, and I'll come back to that in a moment. And then also we have the HER2 climb data, which includes tucatinib, and I'll talk about each of those individually. So now, based on the Destiny 1 trial, we knew that trastuzumab deruxtecan was a very active drug, even in patients with significant prior therapy in the HER2 space. Destiny 3 was really a comparison of TDM1 to trastuzumab deruxtecan, and that trial showed a remarkable, dramatic improvement in PFS favoring trastuzumab deruxtecan, an improvement in overall survival, and at least a trend suggesting an improvement in overall survival, though it's not statistically significant at this point. So what that data has done for both clinicians and patients, of course, is that we now have to question whether TDM1 should be the second line therapy after a pertuzumab trastuzumab taxane regimen. And I think in my own mind, the Destiny 3 data really supplants TDM1 as the best second line choice. Now, with trastuzumab deruxtecan, there are some concerns, of course, with safety because of the interstitial lung disease that was seen. And I'm confident we'll talk a little bit more about that, and I'll put that in context. There are patients, perhaps, who have a rapid progression on TDM1 who received it in the post-neoadjuvant setting for residual disease, where you could even consider trastuzumab deruxtecan as a first-line therapy. But that's going to be a small minority of patients. So for most patients, I think trastuzumab deruxtecan will become the preferred second-line choice. And thereafter, I think you have a number of different options, including the HER2 climb regimen with trastuzumab, tucatinib, and capecitabine. And that's particularly something that would be considered strongly if there was a CNS component to the patient's disease. So patients with active brain mets receiving the HER2 climb regimen responded very well, whether they had brain metastases or not. And in those with CNS mets, active or stable, the time until disease progression was improved. So it's a very attractive regimen for those patients with CNS disease, but it would also be something that we would consider more broadly for any patient post-trastuzumab deruxtecan. And then finally, after that, it's dealer's choice. There's neratinib, there's margetuximab, there's lapatinib. There are different chemo trastuzumab regimens. And there'll be newer drugs coming and efforts to look at how we position even the drugs I already spoke about. For instance, combining tucatinib with TDM1, there are trials looking at that and other ways of moving the drugs up in the algorithm. So the good results have made things a bit more challenging, but it also translates into better outcome for patients.